everyone. Thanks for joining us for the IVI Coffee and Talk. This is the 2nd of March 2023, so our first Coffee and Talk for March. And today we have Adrienne McCann from Age Friendly Ireland and from IVI giving us a talk about her work. So over to you, Adrienne, whenever you're ready.
Super, thanks, Paul. I'll just share screen here. Perfect. So as Paul mentioned, I'm Adrienne McCann. I'm the PI on Healthy Age Friendly Homes, which is a project led out of IVI here, and it's also in partnership with Sláinte Care and Age Friendly Ireland. So kind of a whistle stop tour, I suppose, in terms of what the project is and where we're going forward with it. So in terms of funding, we are funded by Sláinte Care, and we also work in collaboration with those as well. We work with Age Friendly Ireland, who, for anyone not familiar with them, they are a state body really, so they're a national programme based out of the shared service in Meath County Council, but they also have a local programme manager in every county in Ireland. So their role is really around supporting older people across Ireland in terms of listening to their needs, identifying where more work needs, where more supports are needed, and also providing a programme for older people to be active in their communities as well. The Healthy Age Friendly Homes programme itself, I suppose our key objectives within that is around enabling older people to live at home for as long as they can. So you'll hear in the media around, our ageing population, and we now have more older people in the country, and that's obviously going to create more reliance on services, particularly health services and pensions, all these things that we hear about. So a key aspect of the programme is trying to support people at home, more community-based care, but also to live with a sense of independence and autonomy. So you want people to be able to number one, navigate their own homes, but be able to kind of integrate into their communities as well. So it's all good and well being able to move within the four walls of your home, but in terms of the accessibility of your local community, are there bus links? Is there transport links? Have you social supports close by? All of those sort of tie in as well, and ties into objective 3 there around being able to feel part of their community. And then lastly, I suppose the big one, the big outcome that we're looking to measure is around supporting the avoidance of earlier premature admission to long-term residential care. So sometimes you see an awful lot of older people at home and they're living in maybe like older homes that aren't accessible. You'll see the front door and there's maybe 5 or 6 steps up to the door. There's steps between the rooms, in between homes. So it's looking at adapting the home to be able to keep people there for as long as we can. So in terms of the Maynooth aspect of this, so Maynooth are the evaluation partner on the programme. So we currently have about 169 participants taking part, and that's a subgroup of the overall programme itself. So participants who entered into the programme were then additionally asked to consent to take part in the research. So we'll have kind of a bigger overall sample that's taken part in the programme, and Age Friendly Ireland capture that data. And then we have the Maynooth subset, which is where we're looking at both quantitative and qualitative outcomes. So in terms of our quantitative outcomes, we're looking at health status, so the types of, if they're diagnosed with any conditions, whether they're on any medications, how they rate their own health. We're also looking at social support, so for things around the house, or if you had a problem, do you have someone that you could go to confide in? Would you be able to get help with, say, like a small task at home or in the garden or something like that? Would you have good neighbours and things like that? We're also looking at quality of life in terms of how they self-report their own quality of life. And then we look at loneliness and self-efficacy. So should an issue happen to someone, how do they feel that they can cope with that? Do they have the supports there? Are they able to, maybe to kind of sort things out themselves, really? In terms of the qualitative interviews, because it's an implementation study, we're looking at how do we scale this up and how do you replicate this in other areas. So we're using the REAIM theoretical framework. So we'll interview participants around things like the reach of it. So we look to see, are we reaching the target population that we had tried to reach when we first set out to it? In terms of the effectiveness, is the programme meeting the key objectives? Are we doing what we said that we would do? In terms of adoption, in each county, is there uptake within each county? What are the barriers to adoption? Why do people want to take part? Maybe why do people not want to? In terms of implementation, you know, we're in a couple of different counties. There'll be variances between local authorities, variance between people that you're working with. So what are the specific implementation factors per county or per local authority? And then we're looking at maintenance as well. So how do we ensure the, you know, the self-sustainability of this program going forward? How do we keep that there? What resources do we need? So I suppose to give you a bit of an idea in terms of the program itself, what it looks like. So we're in 9 local authorities at the moment, and we have a coordinator on the ground there. So that coordinator, most of them are health professionals, some of them are from local authority background, but majority of them are kind of nurses, physios, and what they do is they identify older people living in the community. So you can self-refer into the program, and you can, a social worker or a GP or a health professional can refer you in, a neighbour can refer you in. And what that looks like then is once you're over 55, our coordinator goes out to you and they will do a full person-centred needs assessment. And that'll look at the 4 domains of housing, health, technology, and kind of community social aspects there as well. So let's say you go out to someone and they're an older person and they're quite isolated, and maybe, you know, they're not registered with a GP, you know, or they maybe don't have any social support, no neighbours, or they're, you know, they're isolated, they've no family or things like that. So they will identify those people to the relevant services. So it might be referral into social work. It could be something as simple as putting in a referral for Meals on Wheels. They, you know, will talk them through the process in terms of, you know, availing of the likes of grants. So like housing is a huge aspect of this. So a lot of the housing grants now, you have your housing adaptations for older persons grants, but then you also have like the SEAI grants as well in terms of looking at the energy efficiency of your home. So, you know, you think of kind of cold, old, damp houses, you know, they're not good for older person's health, especially like respiratory issues and things like that. So once you're generally over 65, it just looks at your income coming in. So majority of people who are just claiming it, if they live alone and they just claim a state pension, generally they are eligible for the full grant. So that could look at, you know, maybe like pumping the cavity walls, it could look at attic insulation, all of these things. So the coordinator will sit down, they'll do all the paperwork for them. They'll contact the construction people to come in to do the works, to do the assessment, and they'll also follow up as well. So they'll sort of track the progress of it. If they haven't been out to the older person, they'll follow up with the contractor or wherever it is. So they're there to kind of do a bit of hand holding, but they're kind of monitoring and supervising that process as well. So just to kind of give you an idea in terms of where we're at the moment, you'll see down here at the bottom left hand side of the screen. So like over half of our referrals that are going out are around housing, so around kind of grants and improving the energy efficiency of home. 16% of those are health, and then technology and community referrals are in around kind of the same there, around 14%. So as I mentioned earlier, we obviously have the bigger sample in terms of that's taking part in the overall programme, then we have the research subsample. But in terms of the bigger sample, there's nearly 2,500 referrals received so far, and that was just from December, so it's probably gone up again since. And we've over 5,000 supports provided. So on the right hand side there, you'll sort of see the kind of key areas that we're looking at. So you're looking at prevention, intervention and reaction. So the likes of an older person living at home, if they're at risk of falls, you know, the coordinator would then indicate, you know, there's a need to look at the housing design or an environmental assessment within the home. They'll then be referred on to, might be an occupational therapist that comes out and does a home assessment. Intervention there, you'll see, we just use one example there of in terms of the number of people who've had a fall. So 217 participants that had a fall, and 44 of those were provided with, were able to go through the housing adaptation process to get a stair lift installed. And then there's another 64 from that have kept the information, but they're just not ready to go forward with it again. And then lastly, and I'll touch on this a little bit more, I suppose, more around the kind of technology and what's available to older people there. And there's been huge advances in technology, and you know, the likes of your kind of pendant alarms, kind of the Pan watch, all these sort of things. So from that sample there, there was 41 indicated they didn't have a pendant alarm, which, you know, generally at that stage of your life, you're kind of looking, you know, now is the time just to have it, even if you don't need it. So being able to provide that information, let people know these technologies are out there, that they're easy to use, there's someone there to talk you through how to use it. It all just helps in the process as well. So I suppose to talk through more kind of technology side of the program as well. So Age Friendly Ireland, very lucky to receive €1 million in funding when the program started from SEAI. And this was on the back of the National Climate Action Plan, where they're looking to retrofit a certain amount of homes by 2030. So the €1 million went towards free home energy assessments for older people in the programme. So it meant the BER assessment, if anyone's familiar with them, they go out and they look to see, right, does your household heat, does it not? And from there you can make a plan in terms of what sort of energy efficient upgrades that might work within your circumstances. We also work really closely with the Tunstall Emergency Response Team based down in Wexford there, and they have a whole suite of resources for older people. So everything from, motion sensors, sort of mats that, if you're maybe caring for someone with dementia, that, and if they're up at night, mats that'll pick up kind of sensory and motion movement as well. Excuse me. We also received sponsorship from Tunstall as well, around to provide Pan watches and Acorn age-friendly tablets as well. And I suppose sometimes the issue with technology and older people is, you can buy the technology, but they mightn't have internet at home. They maybe don't want to sign up to a contract on that, but these actually came with a 2-year subscription of data as well, so they didn't have to worry about going over like an allowance every month or anything like that. It's all included in the package. Excuse me. So this here on the right hand side, this is their Acorn tablet. So it's an age-friendly tablet for older people. It's quite basic, but as the big figures, they can see what's on it. It's, there'll be text message, there'll be, a website where they can find resources that goes onto it. If they want to do a video call, it's all linked up that way as well. And the Pan watches, again, they're brilliant. They have an alarm system built into it. So if an older person is out and about and say maybe they're, down the road out for a walk and they fall, they can press the alarm button on it, which then notifies their next of kin that there's been a fall. But there's also GPS tracking on it as well, so you can then find that person. So excuse me, within that as well, you can set up kind of a safety zone as well, so you can get notified whenever someone is maybe outside that zone.
That's really interesting, Adrienne. I didn't know that much about the project. There's a lot in that, and it's really interesting and overlaps with a lot of the work that we're doing here. But I'll open it up to maybe to those online first of all. Do you have any questions or any comments, any observations you'd like to give Adrienne on the project?
I am.
Yeah, Marco, go ahead.
Yeah. Thanks, Adrienne, for a very interesting project. Yeah, I already knew a little bit about that, but this makes more clear. Just a question is about the holistic approach that you were saying you follow, and is about, and one of the aspects is health, and we've been discussing, and health itself can also now is seen more from an holistical perspective, where you have physical health, mental health, social health, spiritual meaning health, meaningful health, and so these different dimensions of health. So what are you? It's very important for the well-being, mainly for the health and well-being part. So what are you making this differentiation in when you're talking about the health in your case, or are you looking at these different aspects? Are you integrating? Because in any case, you are addressing one or more of these aspects, but are you looking at this more kind of holistic way of looking at health?
Yeah, thanks a million, Marco. So we don't differentiate really out, specifically looking at physical versus mental health, but in terms of the supports, our coordinators are trained in, I suppose, mental health first aid. So when they go out and if they identify someone is potentially at risk or that they would have concerns about, they're trained in terms of how to deal with that, who they might need to be referred to. in terms of our own evaluation that we're doing internally in Maynooth, we do look at like their physical health and mental health. So we would ask them, you know, would you ever experience depression, anxiety? We measure those pre and post. So at 6 months, time 2 is a 6-month follow-up. And we also look at, I suppose, loneliness. And, you know, like a lot of older people, even though they might live with their husband and that, will still tell you that they're quite lonely or they don't get out and about much. I think COVID played a huge part in that as well. You know, being kind of cut off, having to, you know, cocoon. And I suppose in hindsight, like, it was incredibly tough on them as well. So we don't, I suppose, differentiate out specifically, but, and I know like Tom will even tell you, even, you know, some participants that we go out to, and even if there may be, you know, they're not getting any housing works done or they don't really need anything from the programme, the one thing that they would really report back is that they would just feel quite comforting knowing that someone is coming out to check on them, or that if their circumstances changed, they were to have a fall and all of a sudden they did need extra help, they know exactly who they can go to and that they'll come out quite quickly, see them. They're not going to be sitting on a waiting list or that, and that, you know, they have a contact with someone there. So I suppose that the whole kind of huge social support there of having that coordinator role, they're quite a good link role in terms of being able to signpost them there as well. So
thanks, Adrienne. Any more comments or questions from online?
Just one follow. Adrienne, thanks for that. That was really, really interesting. I'm just wondering with the on the technology side of it, and I know you're saying that you could be a self-referral to be into the program, or there could be a neighbour or, I suppose, concerned family member bringing people in as well, or recommending them. Is there much resistance to using the technology, not from the, I suppose, even maybe fear of technology aspect, but from kind of an independent perspective, that they nearly feel that from the people you're dealing with, that there's that you're almost, even though you're kind of giving more independence, but that you could be possibly kind of taking it from them, like almost like too proud to use the technology. I'm just wondering, is there any kind of resistance on that side that you're seeing?
yeah, and like to a certain extent, even, you know, when we introduce the idea of the acorn tablets, people's first instinct is like, gosh, I wouldn't know what to do with that, or I wouldn't know how to, you know, I suppose they still get the option, you know, it's not compulsory that they have to use it, but I think around, especially kind of like our younger old sort of population, maybe like the 55 to 65, when you kind of raise the idea of maybe like the pendant alarm, like if they were to fall, and like, you know, some of those people might still be, you know, in full-time employment and mightn't see that they're that, you know, that they would ever need it, and you would get a bit of resistance that way. But I think generally those who do need it are quite willing to give it a go, but they'll turn around to you and just be like, I found that no use. Like, they'll be very blunt with you whether it was worth it or not.
And through the process that you have then, is there a way of kind of capturing feedback from the participants to kind of feed maybe back into the further UI or UX enhancements for that acorn tablet, or is there a link up there as well?
Yeah, so even, I suppose, like separate to this program as well, like Age Friendly Ireland have run a couple of different workshops with the technology to try and get feedback, and Tunstall have come down to see, to be like, right, okay, these buttons are too fiddly, or I can't see that, or it's not bright enough. There is that kind of ongoing process there as well. So they are kind of tweaking it as needed, like separate to this. So I think this is maybe like the second version of the tablet now that we're on. And they've done a lot of work with kind of nursing homes during COVID as well, you know, in terms of giving out those tablets. So within the program, we're not, unless it's raised by a participant, but, you know, we're not specifically asking the question on, you know, whether they found, we'll ask generally, did you find the support useful? And we'll name off a few to give examples, but we don't have like a specific line looking at that.
Okay, I'll hand over to, I could keep asking questions, I think, on this topic. It's fantastic work you're doing. Thanks, Adrienne.
Brilliant, thanks, Denise.
Anybody else have another question online?
Is that Mansoor hand being up or?
Okay, Adrienne, maybe if I could ask a question, sorry, maybe you did cover this, but I might have missed it. Is it a pilot program or is it fully rolled out across the country?
No, so at the moment it's just a pilot program. So this is phase 1. So we're actually drawn to close in May. So back in kind of December time, Age Friendly Ireland put forward a business case to scale it up for a phase 2 for a national rollout. And in November just gone, they actually got funding from the Department of Health for a full national scale up. Now it'll still be in a pilot, so it'll still just be like a 5-year pilot at that stage at the national rollout. And then 3 will hopefully be actually implementing it into, rolling it out nationally. But phase 2 will be a 5-year term, and this one at the moment has just been a 2-year term.
Okay, and you put it down that there was at the start that I guess the objectives are to keep people out of acute care situations and keep them at home for longer. Is there any indication or data in terms of how successful it is from that point of view in terms of the assessment and the interventions, etc.?
We don't have hard data, which is really what we do want. But I suppose our coordinators at the moment are actually in hospital, so they are there with the discharge teams as patients on the day that they're being discharged from hospital. So they will follow them from hospital straight to home, do the home assessment, see what supports they need, make sure that the home is in place. Or even a couple of days before they're going to be discharged, they'll be in there, they'll get a list of patients to go and see, so they can link up directly with the hospital teams there. So the likes of your social care, your OTs, your physios, all of that. So they'll link in at that stage there. And we have a couple of case studies as well around, I suppose, people who only came to our attention when they were just entering residential care. So they were living in quite poor housing conditions, and the GP phoned the coordinator to say, like, this person's ready to go into residential care, like, can we do something here? And the coordinator was able to go out, have a look, see what they could do. I know, like, in one county, I think it was in Longford, somebody living in very poor housing conditions, and the council actually agreed to put up a modular home on site where their house was, just in the garden, these kind of like log cabins you'd see. And it was all connected to services within 3 weeks. So, like, straight away, that man who was ready to step into residential care and spend goodness knows what amount of money it costs to into care these days, but obviously it was cheaper just to put a modular home there, and it's fully accessible. It's very energy efficient. They're passive homes. There's a wet room in it, fully accessible toilet, everything that you'd need, really, so you do get that kind of joined up thinking, which I think is rare sometimes. So we have a handful of case studies like that, but we really want to try and look to get more hard data on that in terms of how do you measure whether someone will go into hospital or not. It kind of is the sticking point on it at the moment.
Great, thanks, Adrian. I'd love to ask more questions, but maybe I should hand over to somebody else. I see Mansour there has his hand up.
Yeah, thank you, Adrian, for the wonderful presentation. Indeed, the project looks very interesting. So I have just 3 questions. A quick one. What were the challenges which you faced during all the phases of the project? And the second is regarding how do you are dealing with the consent management for the elderly people? And third one is there any access control mechanism already established in this?
Yeah, so I'll start with the first one, the challenges. I suppose the programme itself started during COVID, which was quite difficult given that older people were cocooning. So even trying to identify people at the very get-go was just incredibly difficult. We also had and I'm sure you're all familiar with the HSE, the data breach, or not the data breach, but the hacking at the time, and all the HSE services were shut down. And I suppose at the kind of outset of the programme, that's where we had kind of gone initially to recruit people from, was, health areas. So having no system there has been quite difficult. And from a research perspective as well, I think, like there's a huge sample taking part in the programme, but we've only 170 doing the research aspect of it. And we've kind of had a bit of work to do in terms of, sort of, I suppose, highlighting the role of research and how it's really important to us to be able to get that feedback, that we can take it forward, whether it's good or bad. If they have a bad experience, like, we want to know that too. But some people will just decide, I'd have nothing to tell them, and they, don't consent to being contacted by ourselves. So we're very reliant on our coordinators to consent participants in for us to actually be able to include them in our evaluation. So although Age Friendly do capture their own kind of suite of data, for us as well. It'd be great that we could kind of up those sample sizes there. Mansoor, I'm very sorry, you're going to have to repeat the second question because I can't remember.
Yeah, the last one was regarding, is there any access control mechanism, because it's all the sensitive data is being generated out of these equipment. So is there any access control mechanism which has been established?
On the technology itself, I don't know. No, I'm not as familiar with that end of it. I would imagine they are, because they're, you know, they would have been rolled out to the likes of nursing home patients. You know, they were kind of distributed a lot through COVID, and you know, they've been kind of given to us as like, these are the gold standard of tablets for older people. So I wasn't involved in those kind of initial conversations. I suppose from kind of a access to data in terms of our own side of things. So we are very heavily reliant on age friendly in terms of their anonymization of the data, and obviously a transfer of their data to us. So that's where our kind of data sharing agreement and things come in. But it was a complicated enough process there, given older people are a vulnerable population. There's higher ethical risks doing research with this population. And I know Tom's on here, and it's terribly sad, you know, some of our participants have passed away since taking part, and you know, it's just the demographic that we're doing work with, and you know, you're ringing up, I suppose, family carers, and they're kind of telling you the news at that stage. So there was kind of a whole barrage of, you know, kind of access, ethical issues right at the start that took quite a while to work through, but we finally kind of got it nailed down just with our own research office. So
all right, thank you.
Can I ask
Mark,
you?
Oh, sorry, yeah, go ahead, Bernard.
Sorry, I'm just wondering, Adrian, I'm really sorry I joined 6 minutes in because I had a problem logging in, and so I didn't see your first few slides, but there's a couple of things. There's the slide that explained the tablets, the two people that were at the bottom of the slide, they looked very young to me. One of them was out running, and the other one looked like somebody in the workplace who was about 55. Would they be typical of the sorts of people who you would recruit in? What are your inclusion criteria? And do you include people with things like dementia?
yeah, so anyone aged over 55 can take part in the program, and you don't have to you know, you do, that they're really our only criteria. You can still be working, as in, I've said it to my own parents here whenever it gets rolled out in our county that they should look to see what they can avail of. The only thing is obviously based on your age. If you're, say, over 66 now at our new pension age, a lot of the grants are means tested. So some of the time, if you're, you know, if you're in full-time employment, you won't qualify for the grants, and that kind of puts.
And if you're working, maybe as well.
Yeah, so if you're, or even later on in life, if you're working, sometimes it goes against you in that way. But
because I'm 55 and I'd be mortified if somebody sent me a tablet that had 3 big chunks on the front of it and looked like painting by numbers, I'd think, thanks for that. Do you know what I mean? I'm just curious to know what your typical age would be.
yeah, we have every age from nearly 55 to I think 109 was the oldest.
Okay, wow, okay.
So yeah, you get the full spectrum, but like that, we kind of split it into, we would have like our young old, we would call it, which is sort of the 55 to 65, and then the kind of older old, which is going on again from that. So, but yeah, like that, if you're 55, some of the supports aren't going to be relevant.
I worked in the NHS for nearly 30 years, and I'm never not shocked by how little there is available here for the average person, because you have, everything is really means tested, or if you have a medical card. But the other thing that I was curious to know was with regard to recruitment in the initial stages of your study, how you got past that. About you're talking about times during COVID, and I was involved in a study that was beginning at that point as well, and we had a big problem because you couldn't ask researchers to shortlist from patient notes without the patient's consent, and you couldn't get the patient's consent unless you were referred that person by a clinician, if that makes sense. So I'm just wondering how you got over that, because I know because of GDPR there were some issues around recruitment. You couldn't have people assessing notes in a speculative way. They had to be signposted to them.
Yeah, and that's the way it was for us as well. So, you know, you wouldn't be allowed to see like a patient list or something like that. It was only But really what they ended up doing was they went into GPs, they put up flyers, they put ads on in like the local newspaper.
Okay.
Probably the most effective one that I never thought about, was they put ads on like local radio stations. Do you know, kind of
Okay.
your like
Yeah.
old school LMFM or
Yeah.
Country Mix or Country Hits? Put
Yes.
ads out on that, and the calls rolled in from the
Okay.
radio specifically.
That makes sense. Yeah.
Thanks, Adrian. Sorry to interrupt everybody. I just conscious of the time. We're a minute past 2, so just to respect everybody's time. And you know, people are carving this out for our coffee talk. But I think it was a really interesting talk, Adrian. I have lots of follow-up questions. I might ping you someday next day you're in the office. But I think that was fantastic, and thanks very much.
Super. Thanks a million, everyone.